This is the Equity Charter podcast, where we talk about why we care about equity in the digital health sector and why we think you should too. Welcome to this week's episode of the Equity Charter podcast. My name is Aisha Rahim and I'm a psychiatrist and Chief Clinical Information Officer working in the NHS. Along with my colleagues Hassan Chowdhury and Victoria Betton, we developed 10 principles for embedding equity within the digital health sector. This week, we'll be looking at our final principle, Principle 10, which is equitable health and wellbeing outcomes for underserved communities. And here to discuss this topic with us today, we have our two experts, Rachel Power and Partha Kar. So welcome to the show, Partha and Rachel.
Thank you for having us.
So we'll start off, as we normally do, by asking you to describe yourselves and a bit about your current role. So Rachel, if I can come to you first, please.
So, hello everybody. I'm Rachel. I'm the Chief Executive of the Patients Association. We're one of the oldest patient organisations in the country and we're non-disease and non-condition specific. So we aim to look at issues that affect all patients. And we're here, we exist mainly to make sure that the patient voice is heard in policy, in service design and in the decisions that affect people's health. And we're here to work with everybody in the system, from health creation, NHS, the department, industry, because we believe passionately that if we design and deliver services with people who will be using those services, then that is one way that we can address the inequity that's happening in healthcare right now.
Great, thank you. Partha, what about you?
I've got different hats, but I think in context of this, I am the Type 1 Diabetes and Technology Lead. I've been with NHS England for a decade, basically leading in the Type 1 diabetes space and access to technology and, lots of other roles, getting it right first time. But yeah, as I said, and I'm a clinician working all my clinical work in Portsmouth. But yeah, for the context of this, Type 1 Diabetes Technology Lead with NHS England.
Okay, so we've seen with the NHS 10-year plan this shift from analogue to digital that everybody's talking about. And I just wondered if you both had perspectives on some of both the challenges and the opportunities for patient care in this sort of increasingly digitised system.
If I look at the 10-year plan, and I'll come to the digital side, it looks like a massive wish list to me of what people would want to happen. I think the problem, in my view, is that there doesn't seem to be the follow-up as to how those wish lists are going to be made into reality. And I think that's probably one of the biggest issues. And there are a lot of assumptions there. And I think that's where we need to be careful about. So is there challenges and opportunities? Opportunities, of course. We're a very digital world, but we do struggle quite a lot with people having access to the right digital, the governance side of it. Are they aware of the different groups, what they can access, what not, the barriers based on deprivation, age, ethnicity? The ambitions are noble, the ambitions are great, but my question back to everybody in the sphere has been, I've been long enough in NHS England to see 3 plans now. And my question is, have you implemented everything in the last one before you embarked on another tranche of new plans? And I think that's where, I wouldn't say I'm a skeptic, because I think things can happen, but I think it needs to come with a degree of the how, rather than the here's what we would want to happen. So that's where I think the challenges would sit.
So quite aspirational, but perhaps a bit light on detail from the sounds of things.
I completely agree with what Partha is saying. The 10-year plan came out. It's really exciting. There's exciting things in there. Powered patients, patient agency, unashamedly saying the patients need power. But what we're not seeing is that follow through at this moment in time in terms of delivery plans. Because I think there's 2 sides to this for me. The opportunity is completely real. We've got data sharing. Patients talk about wanting single patient health records for their health. We need to be clear about what it's going to be used for. They want joined up care. So when it works, but we're building a system that has assumptions built into it. So I don't know about you, Partha, but the amount of times I hear about, older people don't do digital, it drives me to dimension. I have elderly family members who are well able to do digital. So it isn't. So we have to understand the issue that we're dealing with, first of all. And I think it is, you think about your coastal areas, your rural areas, the availability of Wi-Fi, the cost of Wi-Fi. The Good Things Foundation talk about that quite a bit. And I think they're the things. So we need to understand the question that we need to be addressing, first of all. So if you think about it, the digital programs are working well for people who are confident and connected. And we have, from my perspective, we have three types of digital. We have those that are digitally enabled. We have those that just need more support to become digitally enabled. And then we have the digitally excluded. Like when we did a piece of work on the NHS app, one of the things that came out from some of the patient focus group was we never explained to people that you didn't need a smartphone, that you can access the NHS app on a website. We're not communicating, we're not giving power to patients so that they can develop those digital skills. Because, we do have a huge proportion of the population who are not digitally enabled and who lack digital skills. So I think we need to think about how does the 10-year health plan, very great visions, how does it design for those people from day one and not as an afterthought in it? So it's not about getting older people online.
Yeah, it feels like a bit simplistic and, just what a basic omission to make, to actually not have explained that there are multiple ways in which you can access some of these digital services. So yeah, really, really interesting. And so I think this is a bit of a loaded question, but, you may both have perspectives on this, but how well do you think the digital health sector, the health sector is at engaging with patients and carers and communities at the moment? I would love to hear directly from you both about that.
I will come in on that, being the patient association. I think everyone believes that they're engaging with patients and communities, but they're engaging with people who have power. And if we're going to design and deliver services, we need to get out there and get beyond ourselves. So at the Patient Association, we don't hold a lived experience advisory panel. And while we did for a specific piece of work, but every time we want to hear from patients, we go out and we do our research, we do our recruitment, we bring new voices into the organisation, those people whose voices are not being heard in the system right now. Now, we could do it an awful lot better. We have an awful lot more work to do in that. But if we rely always on the patient who has power already, then we're not designing. And I think that's what health industry is missing. They're taking the easy option.
Partha, do you have some perspectives on this as somebody that has championed specific digital technologies for health?
I don't think it's done enough. I really don't think it's done enough. The amount of barriers I've had to face and battle just to get the lived experience voice has been phenomenal. As I said, I'm probably one of the longest remaining clinical leads in NHS England, started in 2016. And it's just weird because, the strap line is that we want to do it for the lived experience and improve lives. But there is a certain degree of reluctance to actually engage. I think there's a belief that, in my experience, people want to be told what they want to hear, rather than sit down and go, okay, man. And, Rachel made a brilliant point about the belief that elderly people don't use technology. That's the biggest nonsense you'll ever hear. Right? In my clinic with diabetes, doesn't matter what they eat, they love their technology. Their glucose monitor, they love it. They're like, oh my God, my life changed. I lived with type 1 for 50 years. I used to prick my finger. So the narrative, but it's also plagued us in the diabetes world because even the last data shows that there's a drop-off. So continuous glucose monitor access in this country is in the 90s, 90%, 95, 96, except in the really elderly. And if you go people and go, like, why is it dropped off? Is it because they're saying no? But it isn't. It's because there's an assumption made. So I think it's that sort of example whereby, so to your question, I don't think it's done as well as it should be done, right? I think they do reach out to groups like Patient Association, etc. But if they don't like what they're hearing, they tend to go like, okay, we'll still carry on what we're doing. And that's a weird thing because in an irony, that's why the implementation doesn't happen. So then they go like, why did it happen? Then you go, because you didn't listen to anybody what they said. So Yeah, I think it's an incredibly mixed bag, and I would say there is a real, don't know why, worry within central teams that will people tell us something that we are uncomfortable with, or what shall we do with it? And I think that plagues a lot of clinical leaders and management teams across the board.
I couldn't agree more with you, Partha, and I think that bit about what will patients ask for, can we do it? But if we're communicating, so one of the biggest issues patients have is that the system doesn't communicate and doesn't listen to their views. That actually patients are sensible people, and what they want to do is for the system to listen to them. If they can't do something, is to come back and have those conversations about why and what they could do. And I think that's hits the nail completely, because I think what we're having is consultation. We're not having genuine and true partnership. And, if you look at the different theories of engagement, we come out, the system comes out when it's made a decision about something, and it goes, what do you think about this X, Y, and Z? It doesn't come out and say, we are thinking that we need to do this. What is it you need? As the people who are going to be using the service. And I think that's the thing, is the gold standard isn't being achieved here, because we're not treating patients as equals from the very beginning, and with their lived experience being recognised as expertise. There's two lots. And Partha, I hear you talking about this. You do this with people. There's two people in the room. There's the healthcare professional, there's industry, but there's the patient who knows their body, knows what matters to them, knows what's important to them. And that has to be valued just as much.
Yeah. And I just wanted to stay with you for a second, Rachel. When thinking about the patient community at large, it's not one big homogenous group. Do you have any general sense of how our patients and carers feel about the increasing digitisation of the healthcare service?
I think that's a difficult question, because I can't speak for all patients and I don't speak for all patients. But I do think that if we engaged more, so one of the things the other day that I saw was a consultation around AI, and we talked to a few hundred patients about it, and they were like, you're not talking to us, there's not enough transparency. So I do think we have to have a lot more transparency. But I have heard from a lot of patients that they want a single health record. They don't want to be repeating themselves across time and time again. They don't want to be, one patient said, I don't want to be dragging a suitcase to every appointment with me. I want to work in partnership with my healthcare professional. So, we see the digital app. We know the NHS app. We know that that's loved by people who use it. But there's so much more we could be doing with digitalisation within the system. And that's absolutely what we should be doing. But what we have to do is not forget the people who may not want to use it. We have to keep that front door, that human front door. And I think it brings me back to another conversation, which is, all of these things are great, but patients value that human interaction. They value, so when patients are meeting Partha, they're valuing that. They want that relationship. And that can't all be digitalised. So, digitalise an awful lot, but make sure we don't lose that human interaction.
Yeah. And we've talked about some of the misconceptions that services may have about what they think patients and carers want. And one of those is sort of almost dismissing or discounting an older population in terms of their willingness to embrace technology. Are there other misconceptions that you've come across into people think patients and carers want?
I can give you one example. So one of the things that we worked really hard in tackling the ethnicity barriers. And we had this point of time when obviously the difference between children who were black and children who were Caucasian or white was big. And some of the stuff that people would come out with was quite amazing. It was like, oh, they don't take it because the color of the sensor is white. And I'm going like, I've never heard that before. So when we actually went out, not a single person claimed that to be a reason, because we were very happy to talk to industry and say, okay, can we have different colored sensors if that's the case? So it's those little things that sort of seeds into people's minds. And you go like, and that happens because you clearly haven't spoken to the population properly.
So these are the sensors for diabetes that sit on the skin.
And that's white in color. That's how the black population don't like it. So when we went out, So a lot of mums, they were like, hey, listen, it doesn't matter what color it is. We just want it to, be available. So it's a very good example of, you go like, where does that come from? It clearly hasn't come from any focus group or talking to people. And if you look at it now, all the levels, it's all up in the 90s. Everybody's taking it and it's nothing to do with that. So it's another example of somehow there's a bias being built in, just like we talked about the elderly. Oh, the elderly don't like technology, or it circles back to the question you raised. Is there enough engagement? When you have these misconceptions, it shows there isn't enough engagement. That's why you come up with these theories and beliefs.
And I agree totally with Partha there. And I think we did a piece of work around a core model around communication and trying to. So we went into area of high deprivation and talked to people about actually what did they hear when they were given messages. And if you think a lot of the information that comes out of the system, it's not designed with people. So the assumptions get baked in when we've got a communications team writing a leaflet about something, and then you go and you speak to people. We're doing some translations at the moment of some of our information. Like, our mind is blowing with the focus group engagement with people who are like, oh, can't believe you're doing this. It's going to be really helpful for people. We'll help you all along the way. But we're checking with people who speak the language to make sure that just because we've had it translation doesn't mean that it's right. We're going into focus groups and we're talking to people about it. So I think, there's too many assumptions of what patients want in the system. And if we're not designing at the very first place, the principles of, patient partnership, if that is not true to what we do, then we're going to keep building assumptions about people.
Yeah, absolutely. Partha, I just wondered if you could expand a little bit about your role within NHS as the digital technology lead for diabetes. What drove you to enter that field, and why was it felt that such a role was needed?
So my belief, if I take a step back, has always been that if you look at any chronic disease, right, I think the NHS focuses too much, in my view, on the acute side of it. Well, the vast majority of the NHS is actually chronic disease, right? The NHS is like, let's get 4-hour targets right, let's get elective surgeries right. But if you look at the vast majority of the NHS, it's full of people with chronic disease, long-term conditions. Now, my belief has always been, in a chronic disease setting, it sits on 3 pillars. One is self-management, one is peer support, and the third one is access to a trained professional. And the NHS response to whenever they have a problem is to go, well, let's get more professionals. That doesn't work because you don't have enough professionals. Then you probably don't have enough trained professionals. Then you've got in a dispute about who is a rightly trained professional and all that sort of stuff. The reality is that you probably will see a professional for about 0.01% of your life, right? So if you look at it, my view has been technology can be a really fantastic enabler with the self-management and the peer support. And in the world of diabetes, there is no better way of, here are your lump numbers, here are the patterns. Why didn't you try and do better or try and see what you can help? And hey, listen, it also gives you an opportunity to go and talk to another colleague who lives with type 1 or a friend who's, we tried this. And frankly, that's what's driven the outcome change. It's not been that we have injected a truckload of nurses or doctors or pharmacists or type 1 diabetes care. We haven't. We absolutely haven't. All we have done is we have gone like, right, technology improves self-management, and let's tackle the barriers that Rachel mentioned to make sure technology goes across the board. Internet connection, lack of laptops, proper mobiles, blah, 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 all of that. So our strategy has been, so that goes back to the question. So when 2016, when I joined, I had this big meeting with Simon Stevens and I presented saying, this is my theory. And he said, I like it. Let's try and see. Let's get some data as we go along. But what we didn't do is go full bang everybody and then waste a lot of money. We said, right, we'll do it in, segments. Let's get some data. Let's go back to NICE and we'll let NICE do the cost effective and open the doors for wider pop. And that's how it's done. It's taken time, but that's what drove me towards it. And I think the results now have come out and it looks really good. Our outcomes are one of the best it's been. Our pregnancy outcomes have turned. Again, it's not due to more professionals. I keep on saying this. And as I say, the NHS response to everything is that, let's just do more professionals. And you go like, okay, you don't have enough professionals. What do you want to do now? So that's been my fundamental belief of digital, where it is. Self-management is so under-recognized in this country. Mm-hmm. Phenomenal. It's like, okay, you got COPD, well, best of luck. You go like, well, no. You've got to give them better tools to deal with it. And so that's been my driver in the chronic disease space as to why I've done it.
And I mean, that's so interesting how you've sort of tapped into this massively underutilized resource, which sounds so obvious when you say it out loud. But and you've sort of made reference to this, what has been your model or method of engaging with communities, as a really practical, tangible example for people?
So my view is that I think the power I have comes from the community. And I can't say, I've said this so many times, I am very open to engaging with people with type 1. I've always made policy very clear. I've made very clear what can happen and cannot happen. I've been to any forum I could possibly go. I'm on 6 social media platforms. I engage with anybody, anywhere, right? And in 10 years, I could probably really struggle to think of a single person with type 1 diabetes being abusive towards me. Mm. They have been annoyed because it's not happened quickly enough. They have been disappointed if their group hasn't come earlier. But nobody's had a pop at me in an abusive way or, that sort of stuff. And I think I work very openly with the type 1 diabetes charities, and I will publicly go out and speak for people with type 1 diabetes. So I tend to get emails regularly from individuals throughout the country. I don't know who they are. And they'll say, my doctor is not doing this. And I will always reach out to the consultant concerned and say, hey guys, what's happening? What it does do is I think people genuinely do appreciate when you're being honest with them. I think it's important. So when we launched continuous glucose monitors in 2019 as part of the NHS long-term plan, I was very clear we're doing it for 25% of the population. I said, guys, that's the money we have. I'm not going to give you false promises, but I will work hard to make sure all of you got it. And we got there. So similarly, when we have done artificial pancreas, we've been very clear we're doing children and women trying for pregnancy first. There has been cutbacks to that saying, it's a disappointing, we should not. I said, no. I get it. Women trying for pregnancy or women by nature have been really given a short shift in the NHS throughout course of time. We need to do better. That's my priority play. Now, you may not agree with it, but at least I'm open and honest where I'm going. And I personally believe that if national leaders are more open and honest and say, I cannot do this, you will have more respect from people than saying, we'll do it, and then you don't do it. So that's been my philosophy. And frankly, I think that love and respect and all the thing I get from the type 1 community opens up doors in DH for money, in NICE about approval, systems, everything. So we have been, even in this climate, we have just landed a huge chunk of money till 2029. So people will, how have you done it? I said, well, I think because I have the community with me. So when I sit down with data and the community behind, that's the model I keep on saying to a lot of national leaders. This is not rocket science. I am not a magician. You just need to engage with people properly, with data, with honesty, and doors open.
Yeah, I couldn't agree more with what Partha's just said there. It's a real example of genuine partnership with communities and with people. And that's what we hear from patients so often. But, we talk, they want honesty and transparency. We don't want to hear it's all okay. We want to know, what can we do? How can we work together? People are so passionate about the NHS. They're so passionate about, free at point of entry. That's all. We all want the same thing. And I think sometimes the system ends up trying to tell us how good it is. But actually, when you're that patient sitting at home on a long waiting list or waiting for treatment or where services haven't been joined up around you and you're reliant on the few minutes you get with Partha every year because nothing else has been joined up around you, and that curiosity. I think the other person I talk a lot to is Stella Vig in NHSE, and the one thing we talk a lot about is curiosity. How can we be curious when somebody doesn't turn up to their appointment? Let's not do a DNA on them. Let's say it's a missed appointment and try and work out what else we can do together. They're all the things, because I think if we have that genuine partnership, then we do, like Partha said, it's opening doors because you're proving that you have the community with you.
And this is such a relatable conversation from my perspective as a clinician working in digital myself as well on the ground. This strange paternalism that I sometimes come across, that we don't want to be fully honest or open about things because we're worried we will upset patients, which is quite a patronising stance to take, I think. That really powerful message that you've both given about visibility and transparency, because actually most people are reasonable most of the time, actually. And I think that fear of that message coming back that's slightly unpalatable, I think prevents some of this work that we're talking about. So yeah, really interesting to you both echo that sentiment very strongly too.
Yeah, no, I agree totally.
And Rachel, just to go back to the Patients Association, in terms, you've touched on this slightly already, but I'd love to get into the detail of some of this in terms of a gold standard for how people should be engaging in co-production. Do you have frameworks? What role does a patient association play in helping organisations and services to do this properly?
Yeah, no, absolutely. We have 6 principles we designed with healthcare professionals and patients, and they're simple. But I think if we use them, they actually, well, and actually Partha's spoken to them, so I don't think he knew about them, but he's living them. And they are, treating patients as equals. Their experience and their knowledge of their bodies is as equal as clinical expertise. Both need to be heard in the room. We hear about epistemic injustice where patients' voices are, their stories and their experiences are disregarded as stories. We're not going to have the best outcomes for patients if and some healthcare professionals, because actually that's what they want. They want the best outcomes for patients that they're working with. So making sure that the other principles around making sure that patients are as informed in a way that works for them. So one of the learnings I've had over the few years I've been with the Patient Association is leaflets probably aren't the right thing all the time. So we're doing an awful lot more around animations. We're trying to do translations now. Animations really work for people with low health literacy. So we're trying to do those as well. We haven't done, we're a small team, so I have lots I need to do, but we're trying. I think it's recognising inequalities as well, which I think that's another principle of ours. But making sure that we're designing with people who could be left behind. That's the most important thing, because then it'll work for most people. And that using that shared decision making, if shared decision making was used as a part of that, what matters to you, what's important to you, was core to every interaction, rather than an exception. And, it isn't good communication. Shared decision making is something very different than just good communication and kindness. They're important too. And then I think it is joining services, which goes back to what our other principle is around joining services around patients, rather than patients being expected to kind of navigate a system. Give them information, your social prescribing, your care navigating, all of these really important roles that exist in primary care that will support that shift from hospital to community. So that, back to Partha's point about how often you actually spend with that extreme specialist in your areas. And I think if digital programs demonstrated all of those kind of principles, then we'd be getting into a really good place with digital.
Thinking about carers now, we talk a lot about patient co-production, and I'm just wondering whether there are any particular nuances in working with carers that we need to consider, or does it follow a fairly similar route to how you would engage with patient communities directly?
No, I think they're not exactly the same. I think it depends. Carers come in different shape and forms, right? You've got your parents, you've got immediate family, you've got people supportive, you've got professionals who are carers as well. So I think you need slightly different approaches as you're going along. And I think the most important thing is that you need to explain to family members, a lot of it will do it out of love, right? If you're beyond that and you're depending on professionals, so it's not love, it's a professional job. Okay, they're doing it because they've got the right belief in their hearts and everything, but it's still a job. So you need to make sure you're not giving them something which is now an extra burden on the already things that they're doing. So I think that's a very critical bit. And you see that all the time, unless you can explain to people, no, this is going to make your life easier. People understandably are resistant to change because everybody's up to their eyeballs with the work. So I think that's a very, very fundamental part of how you engage with carers to explain. Just give you an example. If you're in nursing homes and you've got carers looking after elderly population, etc., now use of a sensor and awareness of the alarms helps you to stop these individuals getting admitted. Now, that's the narrative. which is very different from here is a new thing you need to learn about as part of their routine diabetes care. They're two very different dialogues you just had. Because, hey, if you're doing this latter one, which, oh, diabetes things have changed, now you need to learn something new, they're going, oh my God, I've already got 7 things to learn. Another one comes from, and now they're talking. So I think the framing is very important because, as both of you said, at the end of the day, most people are in this profession and job because they want to do the right thing. So you need to peel the right way rather than, and I'll give you a very good example where it may or may not have worked. So let's take the example of the work done for the Oliver McGowan work that's happened, right? Fantastic intent. I know the mum, unbelievable passion. The question I have is mandatory training for people the way to actually impact change and make people understand learning disability and give them better care? That's a fundamental question. I'm not saying yes or no, but is that the right approach where people are going, oh my God, I just need to tick some boxes and get past it and get it signed and get my certificate? Or do you say to people, hey, listen, come on, surely if this was your child, you would want better care than what this kid has gone through? So I think there's a lot of clamor that goes, oh, we need more mandatory training. I am not a massive fan of mandatory training because as a consultant, I do mandatory training. And I know exactly how mandatory training goes through. That's not designed to improve any care, right? We all know this. It's like one of the greatest open secrets in the NHS of mandatory training. So we're missing the point because we're all trying to improve care. But if mandatory training becomes a tick box, that ain't helping anybody, right? So we need to have that discussion about how do we redesign that sort of side of things in the digital space to make appeal to people's, I always say, would you want this for your loved one? Most people I know will go, yeah, okay, all right, let's do it. So that's the framing. I think it needs to be better with the carers and everything around as we go along. And one size doesn't fit all. That's very important as well.
Yeah, so focusing on the outcomes rather than the process.
I think that's it. And I think that, carers can be chronically underserved in the system right now. Let's remember, carers are often patients as well. And I spoke to one carer who was saying to me, like, just even trying to navigate the NHS app as a carer, said both of them were getting appointments in different places. And it really, your comment about parents really hit me there, Partha, because I used to work in a children's hospice service. And my kids were small at that time. And that was where that major realization that being a parent or a parent to a child with, a life-limiting condition, life-threatening condition, two totally and utterly different things. And we put so much pressure on carers and then, financial, emotional and practical. And we're not bringing them in to help design. We need to bring patients and carers into design and deliver services so that, like Partha says, it becomes part of what is the difference we're here to make? What is the role of the NHS? It's there to make people's lives live their best life.
Yeah. And then moving on, and Partha, I know you've already spoken about this very eloquently, but Rachel, I'd be interested in your perspective on this. I'm just really conscious that in a lot of the decision-making spaces around digital transformation, patients aren't in the room, and sometimes that is an omission that needs to be corrected, but sometimes there will be those forums where it is professionals gathering together. And I'm just wondering if you had any advice for people about how they can be effective advocates for patient voices when they're not in the room themselves.
I think I want to bring that question back, because I think what we're doing is we are still commissioning for activities. That's how we work. We base our evaluations on what we're actually doing rather than commissioning them outcomes. And if everything was commissioned for outcomes, then you would have to have patients in the room. And you would have to start with patients. So starting with, what is it we want to do there? What is your experience? What are the barriers you're facing right now? What can't you access? Starting with those questions and designing from there on in. So I don't think there ever really should be a time. It brings me back, and Partha, you probably do your multidisciplinary teams differently, but I remember when I was in hospice as well, and talking to patients in this job was, advice and guidance too, is patient saying, hold on a second, they did that, but they hadn't asked me what the question was I'd like answered. And when it was all over, I didn't get feedback. And where I did get feedback, it wasn't addressing the issue I was facing. Mm-hmm. And I think that goes for digital solutions and digital transformation as well.
So we're not even always starting in the right place with some of these approaches. Okay. So coming to the end of the episode, I'd just like to leave you with another question. If you had a take-home message for people listening who are wanting to either find out more or take some active steps into engaging more in a co-production fashion with patients and carers, what advice do you have? Do you have any resources that you would point people towards? So who wants to take that question first?
If you want to see how engagement works, over the last decade, every year, apart from the COVID years, we have been organising a open patient day. It's not under the auspices of NHS England. I do it on my own, and it's called TAD. It's called Talking About Diabetes. And we just have people coming around and chatting about their experience in their lives. We invite healthcare professionals to come and speak and listen, not speak, listen, just listen. I think it's had its own growth and legs. I think it's a very good example of the patient voice without any restrictions, if that makes sense. I would ask people to have a look it up. And I think one thing I would touch upon, which Rachel mentioned and Aisha, you also mentioned, is that we shouldn't be afraid of challenging ourselves on outcomes. Mm-hmm. Right? And I think the NHS leadership and everything is so caught up in process that any challenge on outcomes is seen as a personal affront. And it's not, right? If you arguments say, cancer care is not improving, that's not to say that the cancer lead is a failure. What we are saying is that, listen, guys, it's not improving, change strategy, change tactics. But we should be measured on our outcomes as leaders. And I think the digital space shouldn't be any different. So if you're going to put digital into people's lives, I think you should be ready to challenge yourself about the levels of uptake. Is it equal? Now, if you're not doing that, you're just ticking a box. And I think that's what I would probably leave a message to everybody. His engagement is being open and honest, and outcomes is where it all is. Everything else is process. You can write a fantastic process report about this, that, and everything, but if it's not got into, the final line I'll leave it. I say this to every trainee and medical student and everybody I say, and sometimes it slightly winds up academics, but I always say the best research in the world is the one that gets into people's lives. Yeah. Otherwise, it's a bullet point on your CV. That's all it is. It's made you famous. It's not helped anybody else. And I think we need to bring that approach into leadership when we're engaging with people, because that's the job. So that would be my leaving message.
So I think my first one would be around do not assume anything about what patients want. Show that curiosity, go out and ask them, and repeatedly, and ask them for their second opinion. Keep asking till you know that you've really understood what patients want. I think for me, measuring outcomes rather than activities, I know Partha gave that one, but I think that's really, really important. Remember the importance of that human interaction between patients and their healthcare professionals. So digital can do a huge amount, but it cannot take away from that need. That the doctor's days, as somebody said to me the other day, the doctor's days AI assists. It's really important, and patients value that. And I think the one question I would want them to be able to answer is, if you can't tell me what underserved communities are doing better as a result of that digital program, then you don't know whether it's working or not. And that's the question we have to keep asking ourselves.
Thank you both very much for those insights. It's been a really fascinating and thought-provoking conversation. So all that remains for me to do is once again, thank you for your time. Thanks, Partha, and thanks, Rachel. Thank you for tuning in to this week's episode of the Equity Charter podcast. Don't forget to rate, review and subscribe to the series. And if you'd like to know more, go to our website at www.equitycharter.digital. You can follow our page on LinkedIn, join our community of practice, and you can also contact us at hello@equitycharter.digital.